is knee, shoulder, and elbow septic arthritis. Is there a difference? And as I started preparing for this talk, my first reaction was there hardly seems to be any difference. The basics remain the same. So as in any other joint, the diagnosis of septic arthritis of the knee, shoulder, or elbow is based on a combination of good clinical history, physical examination, hematological investigations, microbiological investigations, and radiological imaging. And treatment consists of a combination of medical and surgical treatment as described by Mandar previously. So is there any difference? And if you delve deeper, you will realize that every joint has a slightly unique pattern of involvement, some unique sequelae, and some unique problems which have to be tackled. For example, when we talk about the hip, in terms of sequelae, we mainly have to deal with limp and instability. We have a full 1 hour section dedicated to hip septic sequelae. So in this talk, I will mainly direct my points towards sequelae for the knee, shoulder, and elbow. So first, let's talk about the knee. And in case of knee, the sequelae which occur because of growth arrest at the distal femur or proximal tibia are mainly limb-length discrepancy and deformities. And both limb-length discrepancy and deformities can be quite severe because, as we know, both distal femur and proximal tibia are growing ends of the bone. The literature on post-septic sequelae of the knee is sparse, but this 1994 study, it shows it studied 73 knees in 69 patients with septic arthritis of the knee joint, and they showed that the sequelae are most common in children less than 2 years of age than in older children. These authors, they identified two patterns of involvement. In one, there is a metaphyseal defect and the epiphysis migrates into the defect. The other is the curious case of missing condyle, where one of the condyles is disappears, and this may either be due to delayed ossification of that condyle or it may be due to true destruction. This pattern of missing condyle was further elaborated on by Dr. Hitesh Shah and Dr. Benjamin Joseph from Manipal, and they proposed an interesting hypothesis for its causation. They proposed that the persistence of a synovial spica in the knee, which partitions the knee into medial and lateral compartment, results in infection of the knee joint being confined to one of the compartments, and that would explain destruction of selectively one condyle of the knee joint. A few reconstructive procedures have been described to reconstruct a missing condyle, but the results have been largely poor. So this has a poor prognosis. To give you a few examples, this is case example number 1. And as you can see, there is a large central growth defect. And this mainly leads to limb-length discrepancy. The deformity is not too severe. So cases like this, where there is just limb-length discrepancy without deformities, are relatively straightforward, and these can be managed with just limb lengthening. However, cases with deformity and limb-length discrepancy are more complicated to manage. So this is a 2-month-old child with septic arthritis of the knee joint, presents at 8 months with progressive genu valgum, and as you can see, there is a missing lateral condyle. At 18 months, the deformity has further progressed. So at this point of time, we decided to implant an 8 plate in order to try and see whether we can halt further progression of the deformity. Progression of the deformity was halted, but the child then required a deformity correction surgery at the age of 3 years. And this is the child now at 4 years. We know that the child still has a long way to go to skeletal maturity, and he is going to need multiple surgical reconstructions. So such cases where there is a missing condyle or there is a growth arrest in the distal femur, they require repeated surgical interventions till skeletal maturity. Another case, 6-month-old child, again, septic arthritis of the knee, presents with progressive genu valgum. And at the age of 3 years, the child underwent a combined osteotomy and 8-plate implantation. This is the child at 5 years, and at which time she underwent a limb lengthening surgery. And this is the child now at 8 years. Again, clinically, she's doing okay at this point of time, but we know that she's going to need further surgical reconstructions till skeletal maturity. Now coming to the shoulder, and shoulder again has its unique set of complications. However, what should be noted is that the complications are most common when the affection of the joint is in early infancy, that is in below the age of 18 months. So what are the different complications that we see in the shoulder? Number 1 is the subluxation. This is especially seen when septic arthritis of the shoulder occurs in children less than 2 years of age, and there is a delay in surgical intervention in terms of drainage of the joint of more than 10 days. This may be considered analogous to hip dislocation following septic arthritis of the hip joint. Another complication in the shoulder septic arthritis is shortening of the humerus, and this again can be explained because the proximal humerus, as we know, is the growing end of the bone, and growth arrest at the proximal humerus can result in significant shortening of the humerus. If this shortening is severe enough to result in functional deficit, then in some selected cases, humeral shortening may be indicated. A third unique complication of septic arthritis of the shoulder is proximal humerus varus. This leads to restriction of shoulder abduction and subacromial impingement. If left alone for a prolonged period of time, this can even lead to rotator cuff tears. This condition is managed by proximal humerus valgus osteotomy, which usually helps in improving the range considerably. Finally, coming to septic arthritis of the elbow. An elbow is a joint which is affected by infective arthritis very rarely. In fact, traumatic affection of the elbow in children is much more common, and therefore it is not uncommon to miss a case of infective arthritis and label it as a trauma. In fact, in this series, which was published in 2010, the authors described at least 4 cases of elbow septic arthritis, which were initially misdiagnosed as pulled elbow. Another unique feature of elbow septic arthritis is that many of these cases have a subacute presentation rather than an acute presentation, though the reason for this is not exactly known. Another important point regarding elbow septic arthritis is that concomitant osteomyelitis is quite common, and therefore MRI should be considered an integral part of diagnostic workup in septic arthritis of the elbow joint. Therefore, to conclude, I would say that the basics of primary treatment remain the same, whichever the joint. However, each joint has some unique patterns of involvement on sequelae, which we should be aware of so that we can manage them more effectively. Thank you for your kind attention.